Okay, examination begins by looking at the back of the shoulders. We look for muscle bulk, muscle definition of the deltoids, the side deltoids, the back deltoids. We look for the muscle definition around the shoulder blades, the back of the shoulder blades themselves as well. Then and also adverse tension, particularly here in the middle trapezius muscles, and lack of definition of the lower trapezius muscles, and even overactivity of the rectus spinae. Then we get the person to take both their arms up over their head, and we just look to see how the shoulder blades come up with the shoulder and come back down again. And on the reverse movement, we also look to see if the shoulder blades suddenly coming down with a shudder, or whether it's a nice, smooth sort of action. Tim will just demonstrate a classic impingement type of movement, where people elevate the whole shoulder up to compensate for lack of supraspinatus. The shoulder blade will take off away from the rib cage, and hence we have an abnormal, what we call scapulothoracic and scapulohumeral rhythm. So shoulder blade, arm rhythm, and rib cage rhythm can come back down. Okay. You can also see if there are any dimples at the back here, which may indicate tightness of the posterior capsule, the back capsule of the shoulder, which is particularly important for many conditions of the shoulder. Because if this capsule is tight back here, what happens is as the shoulder goes, or arm goes up, we need to turn our arm outwards. As we're turning outwards, this capsule, if it's tight, tracks underneath and pushes the ball up into the socket. So it pushes this arm back up into the socket, which then traps underneath, or traps the supraspinatus muscle underneath the acromioclavicular, the AC joint. Okay. The test for shoulder impingement, or impingement of the supraspinatus, one is called the empty beer can test. Normally you stand in front of the person, and with the arms around 45 degrees away, we just test to see whether there are any symptoms as they push up in this position. The other test for the bicep through here is to do what's called a speeds test, where they resist and come up, and resist again, and you're asking for symptoms and looking for weakness and the ability to do that. And we've got what's called O'Brien's test. That's for impingement and basically capturing of the bicep tendon inside that ball and socket groove. Ball and socket, where the bicep actually comes in between the ball and the socket. So what we do is we ask them to hold there, and then stabilize, get them to turn out, and again, just test that movement. So, turning in, ask for symptoms, and then get them to turn out and see if the symptoms are the same. If the symptoms go away, that's suggestive that the long head of bicep has moved outside of that entrapment. The next test is an Hawkins-Kennedy test, but with a bit of modification, where just try to relax that shoulder a little bit, and just stay here and don't let me push you down. So hold that position, and don't let me push you down. And again, if they're symptomatic, there will be a lot of weakness there in this. Yeah, hold that there, and hold that there. Always test both sides, because quite often they can have the weakness on both sides, even though one side has pathology. Okay, and I'll get you to take a seat. And the other tests that I like to do are the isometric tests in this position, where you just hold that position, Tim. Hold this position, and we're just feeling to see if the head of the humerus, of the arm, is sliding forward and backwards in the socket. And testing this one and testing that one. Same time, you can see how well the shoulder blade, to stay here, hold that position, how well the shoulder blade can stabilize here on the rib cage. Beautiful. Okay, great.
Okay.
Okay, in this position we can also test for apprehension. Do they want to come here, or do they want to protect themselves, not go into that position? Some people refer to it as a something-nothing, where they go to throw and they feel like something's giving away, like a nothing feeling in their symptoms. So you can just test that by seeing if there's some apprehension, some instability. You don't go very hard, you're looking for apprehension, and you're not trying to re-dislocate or sublux their joint. This technique is a very good technique for improving the sideways motion of the shoulder. It also improves frequently neck restrictions of motion, both rotation and side bending. It's designed to try and relocate the ball back into the socket, and at the same time have my thumb on the 3 lower vertebrae of the neck, either C5, 6 or 7, and even sometimes the first ribcage vertebrae, T1. After 3 sets of 7 repetitions, we re-examine the motion after each set, both the arm motion and the neck motion, to see what has improved. The activity or the exercise and the technique should be pain-free throughout. Thank you.